2 years ago, the Commission heard from a presentation from HealthLink, one of our state's federally qualified health centers in Northwest Indiana, about their work to develop mobile integrated response system. And this is aimed at supporting individuals with substance use disorder and shepherding them into recovery. Since that time, DMHA has made a significant amount of progress, and FSSA's Division of Mental Health and Addiction has contracted with Third Horizon Strategies to evaluate Indiana's 11 MERS teams and provide recommendations on how to sustain and expand the program moving forward. So I've invited Mark Loggins, the Assistant Director of Addiction Services at DMHA, to provide a brief recap of the MERS program and introduce Sarah Howe with Third Horizon Strategies to walk us through those findings of the evaluation and share the impact of one MERS team is having across multiple counties. So Mark?
Thank you very much for having me. Good morning, members of the Commission. My name is Mark Loggins, as Chairman Hunsinger said, and I serve as the Assistant Director of Addiction Services at the Division of Mental Health and Addiction. Thank you to Chairman Hunsinger for allowing us the opportunity to speak today about the Mobile Integrated Response Systems, or MERS, projects, as you'll probably hear it referred to throughout the presentation. In previous meetings, you may remember this project being presented by my colleagues at DMHA. The purpose of today's presentation, as Doug referenced, is to give a very brief overview of the MERS program, share with the Commission a high-level overview of the evaluation and of this evaluation of this project, and then have one of our MERS providers, Integrative Wellness, share what their program does in their community. So the Mobile Integrated Response Systems, or MERS program, began in 2019 utilizing a supplemental award from the State Opioid Response Grant. With the funding from this federal discretionary grant, Indiana released a request for funding opportunity for providers to implement a novel concept with several evidence-based elements, including quick or mobile response teams, peer recovery coaches, medications for opioid use disorder, trauma-informed, recovery-oriented systems of care, and naloxone distribution. All had previously operated as individual projects with other grant funding prior to MERS. The MERS providers have been tasked to meet several program guidelines for their communities, including a mobile team comprised of peer recovery coaches, a clinician, and the option to add a prescriber or a first responder, whether that be law enforcement or EMT. The team is tasked with responding to referrals for persons in need of opioid or stimulant use disorder services within 72 hours of the referral. The second element or guideline they had to follow was a trauma-informed recovery-oriented system of care, or a TI-ROSC, as you might be referred to later, to support the team and coordinate services in the community. Third guideline, peer recovery coaches with the ability to meet people in the community or in their places of need, including a local emergency department. And lastly, a cooperation with an FQHC, a CMHC, or other certified healthcare entities to perform ongoing services, including wrap-around services and services related to social determinants of health. From the initial RFF, or the request for funding, Indiana had 7 providers covering over 15 counties across the state. Through further expansion, grandfathering in of a program, and a subsequent expansion RFF, the MERS system expanded to 11 vendors serving over 30 counties as of September 2023. Across all of these services that these teams provide, they have served over 16,000 people since 2019. The MERS program is 100% funded by the federal SOR grant, and while it seems like the SOR grant will be renewed in the coming year, DMHA is mindful that this discretionary federal grant is not permanent and is very invested in the long-term sustainability of grant-funded programs like MERS. In order to begin the work of forging ahead on sustainability, DMHA first needed to fully understand the MERS providers and the services that they provide. Third Horizon Strategies was selected through a competitive RFF process to provide a robust and comprehensive third-party evaluation of the MERS project. The evaluation began on December 2022 and concluded with their report on September 29th, 2023. I'd now like to introduce Sarah Howe from Third Horizon Strategies to present the evaluation findings. She will be followed by Lynette Clark and Maddie Combs from Integrative Wellness, who will present on the InWell MERS program.
Well, thank you, Mark, and thanks to the members of the commission for the opportunity today and for your interest in this program. As Mark said, I'm Sarah Howe. I'm a senior director with Third Horizon Strategies. If you don't know us, we are a boutique healthcare advisory firm out of Chicago focused on improving the healthcare system across the country. We do work in several states, including Indiana, and I'm thrilled to be here. And have to say, as a Purdue alum, I'm thrilled to be back in Indiana. So thank you for that indulgence. We're going to talk today about 6 areas: the background and what the evaluation objective was, which Mark touched on a little bit, an overview of the MERS structure. So for some of you, this is going to be a little bit of a refresh, but we want to talk to you about what we saw, what the partners look like, what the staffing is, some of the key themes that we got out of those site visits, what is the data that we've analyzed, and then some best practices, some lessons learned, what are the challenges, and our recommendations from an evaluation point of view. So Mark mentioned some of this, but one of the key things I wanted to point out as well is that we specifically went to every site, all 11 MERS sites. we were on the ground and spent an entire day with them, working with them to learn more specifically about what they did, how their partners responded, and what their staffing structure was. So that was a really key component of the work that we did. The methodology, I will tell you that I should have had my other glasses so that I can read that. So I will look down here a little bit. So we did a couple of things. First, we went into their documentation. As Mark pointed out, they had already had an RFF, and we looked at their response to that RFF. We looked at their data. They do provide data to SAMHSA through GIPRA, the Government Performance and Results Act, so we were able to review some of that data as well. We compiled those data sets. We also developed our own formal assessment tool that we utilized for every site visit, and then of course we went on site to talk with them as we walked through that tool. What you see here is just a little bit of background, and I imagine this commission is pretty aware of some of this data, but we just wanted to point out what we're seeing here. That red line is where Indiana is. So from 2011 to 2021, the death rate due to opioid overdose increased from 5.6 per 100,000 to 34.2 per 100,000 in Indiana, with the drug overdose mortality for any drug being 43 per 100,000. That was in 2021. In 2022, there were 2,250 deaths from overdoses of any drug and over 17,000 emergency department visits in the state of Indiana. And then from 2003 to 2018, the opioid epidemic cost Indiana $43.3 billion. So I wanted to give that background for why we do this work, why we continue to move forward on the MERS project. So let's talk about the structure and what you see here. So in the heart of that, the center of that is what the MERS team is, where they are in all the different groups they touch. So what you see here is a little bit of everything. So case management being at the top, but then we look at employment support, treatment, specifically for MOUD, so medications, is really key piece of this. We touch criminal justice, we touch re-entry at the MERS programs. We look at medical services, physical health care. One of the things that we know when we talk about someone with a substance use disorder is that they are likely to have a chronic underlying physical health condition. So the MERS teams help bring that out too, because they often don't necessarily have that connection to medical services until they get integrated with a MERS site. We also help them with education, transportation, and then one of the key things we're going to talk about later is peer recovery support services. So what you see here is really a multifaceted approach that's rooted in the social determinants of health that really integrates the individual that is experiencing their substance use disorder, helping them get the services that they need and get them on that path to recovery or stay on that path to recovery. What you see here is a map of all the sites. I promise I won't read them all to you. You have them in front of you. But what you see is a map of each of the sites and who they cover. So each county is in a different color. So you can see many of them have 3 counties. There are a few that only have 1, and that would be some of our larger counties in Indiana. And then in southern Indiana, we have a broader scope of services as well. So that is all of the sites, and we went to every one of those sites when we did our visit. Okay, so there are 3 models that the MERS team operate. Mark touched on this a little bit, but we wanted to highlight them. There are 3 ways that a MERS site operates. One is they're a certified community behavioral health clinic. They could be a federally qualified health center, or also sometimes called a community health center, or they're a primary care provider. And the MERS program is run as part of that organization. So they're an add-on or an adjunct to the work that they're doing on mental health and substance use services. That's the first way that the MERS could be employed. But the second, they could be a behavioral health and addiction treatment or a recovery support services provider. You might also hear the term recovery community organization or an RCO. They can be housed in one of those types of sites as well. And that's implemented as a component typically of their larger behavioral health or their substance use services, and they integrate MERS into their services for behavioral health. It could also be a standalone program. We did see that with a couple of sites, that was really the cornerstone of the work that they do. And then we do have one particular site that is a coalition of service organizations. So they came together very specifically to create the MERS program and utilized all of their community partners together to create one coalition. So that is a third type. We have one of those right now. There is a list of all of the different sites, and we put them by model. So that first model you see that we talked about, Model 1, which could be CCBHC, Primary Care, FQHC, that would be Oak Lawn, Good Samaritan, Eskenazi, Davies, and HealthLink and Integrative Wellness. So we talked about hearing from HealthLink recently, and you're going to hear from Integrative Wellness later today. The second model is Turning Point, Phoenix, Choices, and One Community, One Family. And I do want to point out, Choices and One Community, One Family do often work hand in hand in Southern Indiana to do their work because they cover a very broad geography. And then that third one that we talked about that came together as a unique model is the Lutheran Foundation, and they are called the Hope and Recovery Team. So their staffing really varied by the type of model that they have. So going back to those initial models, what happened is either they set up a distinct MERS team or they added existing responsibilities to the MERS existing responsibilities to the staff that they already had. So Model 1 typically included substance use disorder clinicians, therapists, supervisors, nurse practitioners, physicians, or peer recovery coaches. One thing I want to note that you're going to hear over and over is that cornerstone of peer recovery coaches. That runs throughout this entire program, and we're going to talk a little bit more about that. The second model is part of a larger substance use community response. So there were multi-organizational agreements and resources that were added to this. So again, they include peer recovery coaches, supervisors, clinicians, and therapists. And then that third one that we talked about, that distinct model that we have, it included the same group of people, clinicians, therapists, medical personnel, first responders, law enforcement, that they created it as a coalition model, probably would be the best way to explain it. So the partnership, when we went to these sites, the first thing that we heard, probably the most consistent, and what we heard a lot is that these partnerships are extremely valuable to the MERS sites. Without them, it would be very hard for them to do their work. So we really wanted to highlight where you have a parent healthcare facility, like a federally qualified health center, or you have a CCBHC, the team relied on the partners within that healthcare facility for referrals. So if someone could come into the FQHC, they find that they do need substance use disorder treatment, they need some recovery support, the MERS team would get that referral, and that they would immediately wrap those services around them. That's in that first model. Where it's part of a larger community response, you would see them work very closely with their partners in the community. So referrals could really come from any number of sites. For example, if you have a local EMS and they see someone experiencing an overdose, then they could refer to that MERS site. That was the second model. And then the third model, they had some really unique elements there where they came together we had law enforcement, we had clinicians, we had different social service organizations. Each of them had referrals and would refer back to the team depending on what they needed. So if somebody needed transportation, they would refer to that right organization. If there was a law enforcement partner, they would find out what services they need to help them maintain their recovery. Okay, so let's go into some of the key themes that you see here. What I wanted to point out here, these are the things that we heard repeatedly across the state as we were looking at this program. So limited transportation. I will tell you, every single site that I visited said there were limited transportation options, and that could be right here in Marion County or in Davies. It did not matter from across the state whether there is public transportation options or limited Uber options. Every one of them said that was one of the barriers that they saw, and it was a barrier to recovery. So many of these sites really tried to work uniquely to help assist in those transportation options. We certainly know if somebody is on their path to recovery and can't get transportation to a job, that's a very difficult barrier for them. So we heard that repeatedly. Unhoused populations, again, across the board, we heard that there are limited housing opportunities. And there are limited housing opportunities for people in recovery. Sometimes landlords aren't necessarily wanting to give housing to somebody that is in recovery, even if they have a site that can vouch for them. And then a lot of times housing was just limited in general for them to get housing. And this was, again, not specific to one area of the state. The other piece that we heard repeatedly, and this is no fault at all on the grant at DMHA, this really goes back to Congress and SOAR funding. So the state opioid response funding is very specific to opioids and stimulants. And that is where this funding has to be utilized. So oftentimes somebody would come in with an alcohol use disorder and they could not serve them because it did not fall under the state opioid response funding. Now I will say, I have to give credit to the sites that they were very engaged in trying to help. So if someone was, for example, experiencing an alcohol use disorder, they would still try to refer them. They would try to get them where they could get services. A lot of times they did it pro bono. They really didn't want to leave that person out. But there were instances where every site told us sometimes they had to turn somebody away because the funding just did not allow that. So that's one thing. But two really exciting things. One, in every community where there is a MERS site, they have said it contributed to a positive change in attitude. So when we work in this field, we see sometimes a lot of stigma. I'm sure you've heard about that as a commission, that we see that where people, whether it's getting jobs, where people are assuming that someone in recovery, it's a moral failing. What they have found that where these sites are, there's been a positive change in community attitudes and there's been support. And one of the sites told me specifically, it was a law enforcement site, that said when they first started working with this program, their colleagues in law enforcement had said, they called it the Hugs for Thugs program. That was what they first called it. And they said what happened was several years later now, those same law enforcement officials had actually done a raid on a home, and instead of turning them all over to being incarcerated, they found that several of them had a substance use disorder, and they called the law enforcement and said, I think these people need help. They certainly needed to handle the law enforcement side of it, but they also wanted them to get help. And they felt that that was a huge shift even in how law enforcement was handling substance use disorders. And then finally, Mark did not pay me to say this. We did this independently, but every one of the sites said that DMHA was very responsive, was a resourceful partner. I will tell you, we said to them, if you have any concerns, if you have any issues, now's the time to share it because we can provide that feedback. And every one of them said that they were really thrilled to be working with DMHA. They felt they were super responsive at any time they had questions, that they would always answer them. So kudos to DMHA for that. So let's talk a little bit more about the community benefit, which I think is one of the really key pieces here that we found when we talked with different partners. So one of the things that we did was ask for partners to come to every meeting. So these are organizations, whether they were law enforcement, whether they were the sheriff, they could be a local hospital, but we asked them to come and talk to us about the benefit of the MERS program in their community. So here's what they said, that they were able to have, they were more accessible, they can get assistance quicker, that was really important, they can respond to those emerging needs. They found that they were a group that could tell them what was happening on the ground because they were responsive and aware. So they're really the heart sometimes of the, I would say the opioid epidemic response, but I think in this case it's even larger than that, but they have been really a key partner in that. And then that peer recovery support that I've mentioned several times was really, really critical. That is something that we have consistently seen, that when somebody's on their recovery journey and they have peer recovery support, somebody that has walked in their shoes and can say, this is a path that I've been on, I understand. They found that was of just incredible benefit. And it was something that even the partners found, that when they could reach out to the MERS site and say, is there a peer? That had helped them and help that person that is experiencing their own disorder get on that path. So that was really critical. And then the other thing, as a commission, you may have talked about the workforce crisis that we're seeing in behavioral health. What we found consistently is that this program really helped with a vital workforce pathway, particularly in that peer recovery space. And we talk about a little bit later in our report too, but this is critical. There is very low turnover in that peer space, and they were able to bring in more peers so that we found a new career pathway. And I can tell you from the work that I've done across the country, I have noted this particular model to other states and said, this is a pathway as we try to work through this workforce crisis, which we know is really daunting for the work that we do. So let's talk a little bit about the data. So this comes from the data that the sites gave us. So this is their own reporting data that they provided, that Government Performance and Results Act, or GPRA data that goes through the SAMHSA. So what you see here is just some basic demographics. So close to a 50-50 split, a little bit higher on male versus female in terms of the demographics. And then overwhelmingly what we saw in the MERS program is 88% white. And then we have the breakdown, 6.6% Black African American, Hispanic Latino 3.6%, and then we have some other percentages there. So these are our demographics. Also, across all sites, the average age was 36 years old. The oldest person that was served was 78, and the youngest person served was 14. So we did have a range, but the average was in that 36%, or 36 years. So here's some of the baseline data. I'm not going to necessarily read all of that to you. You can see some of it on your slides, but can tell you how many were employed, how many were attending school. This is when they came into the MERS program, and then we're going to talk about later what that looked like. So we did have roughly a third that were employed or attending school. We have about 43% that were looking for work, 40 that were not looking at the time, 12% that were disabled. In criminal justice involvement, 9% reported being arrested in the past 30 days. That was upon intake when they first came into the MERS program. And then you had about a third that were awaiting charges, and 39% were on parole or probation. We've talked about housing, so I want to again point out that this is a really key piece, that what is housing stability, what that looks like. So hang on. Couple things. So 67, roughly 68% were housed at intake. That is how they reported it. So what they mean by housed could vary by what the individual says that is, but that was what they reported at intake. And then we were able to dig a little deeper in some of them with 46% actually own or rent an apartment. 37% live in someone else's home. So that's a key piece when we talk about what housed means. And then 16.3 at a halfway house, residential treatment, or another housing situation. We did have some missing data on that one as well. Of those that indicated they were not housed, this tells you a little bit. 20% said they were in an institution. About 8% were in a shelter. 2.5% were living outdoors. And 1.3% we don't have that information. And then the emergency room intake, 16% had some emergency room involvement in the last 30 days. So what are some of the commonly used services? So the most common used service for a MERS site was case management and recovery support services. If you're not yet seeing a theme on the peer recovery support services, here we are, right? So that was the most common service modality that we saw. But there were also treatment services that were deployed. So if someone was in need of substance use treatment, they were able to get screenings, referral, they could get treatment planning. They can also be referred to treatment upon discharge. That is something else. And then those peer-to-peer services. Again, and you see this here, clients engaged in peer coaching on average 12 and a half services when they were engaged in peer coaching. So we see, again, that theme of peer recovery support. And we're going to talk about why that's really critical in terms of the data here soon. So, outcomes. We have two slides on outcomes that are really important. So this is the overall outcomes that we received. This is, again, through the GPRA data, but this is for the entire program. So what we saw here upon intake and follow-up, I want to really highlight. So abstinence, so they did not use in the past 30 days. You saw at intake about half. At follow-up, you're at 69%. So that is a 35% increase in abstinence of use of alcohol or illegal drugs. In terms of past 30-day arrests, they went from 90 to 87, so roughly the same. They did go down a little bit. In terms of the data, we weren't able to dig into what that meant because you remember some of them were also awaiting some charges, so I would take that one with a little bit of a grain of salt, depending on what happened in the follow-up with them. Education, we do see they went up, whether they were attending school or employed, we went up from 37 to 50%. The health, behavioral, social consequences. So what does that mean? When we're talking about somebody who is actively using, there are obviously social consequences. They define that, what that means with your family, with your friends, with your colleagues. What we see here is they went from 60% where they experienced no consequences up to 71%. So again, we're seeing this trending in the right direction as part of the program. Social connectedness did go down a little bit. That is, I've actually asked our data team, what does SAMHSA define social connectedness? And it doesn't have a great definition. Again, it's what does someone believe in terms of their social connectedness, but it is a measure, so we wanted to point it out here, that we did see a little bit of a dip from 86 to 79%. Stability in housing did go up 38 to 44%. With that being one of the key measures that we talked about is housing instability, that's really critical. And then the emergency department mentions, so they had involvement, 18% had involvement in the past 30 days when they started. It went down to 9% that were in the emergency department in the past 30 days. So that's also a critical piece. Excuse me. Here's the other piece that I really wanted to touch on. So part of this program is having access to medications and medications for opioid use disorder. So what you see here is, as we teased out those that were on medications, those that were not, roughly 11% were utilizing medication-assisted treatment at intake. That's what we saw. And so then we looked at the 6-month follow-up, and those same outcomes that we just talked about, what is the difference when somebody is on medications and somebody is not? And this data is really fascinating and really kind of exciting. When you look at, again, abstinence, someone that was on medications versus not, you saw a 65% change for those that were on medications. So telling us that MAT was working in terms of abstinence. In terms of past 30-day arrests, those that were on medications had a positive change in terms of less arrests in the past 30 days. They hadn't had any, a 13% increase, versus those that weren't on MAT, there was that small decrease when we teased the data out that did have arrests in the past 30 days. That's one of the key ones I wanted to point it out. The other one I really wanted to highlight here, though, is the housing piece. So stability in housing, for MAT, it was 15% change versus a 45% change. So that's where the one area where we saw a dip, where we didn't see a positive increase if you were on medications. And you might ask, why is that? Oftentimes what we heard from the sites and what we heard from clients themselves is if they are on medication, sometimes they do get denied care. They do get denied getting into a place, whether that's housing, an apartment, or sometimes that could be even in a recovery home situation. So that's one of the areas that we know we need to do a little bit more work on in terms of trying to get people that are on medications stable housing. So what are some of the things we've learned? If you're not surprised probably by this slide that the value of a peer recovery coach, but I think it's really critical. It is the cornerstone of this program, and Maddie and Lynette will probably talk a little bit more about how important that has been for them, but it really fills a critical gap in the support structure right now. It's something that as a field we have worked very hard to try to get more peer recovery coaches, and we have seen it in action with the MERS program. So again, this is a strong piece of it that we want to make sure as MERS goes forward, we maintain that peer recovery support coaching mechanism. But it really provided also not just that workforce pathway we talked about, and not just the support for the individual that is getting services through MERS, but for the peers themselves. The peers themselves told us that this was absolutely valuable to them. It helped them maintain their recovery. They found that it was really impactful, and it helped them continue their work as well. So and I mentioned this earlier, there was a very low turnover rate for peer recovery coaches, and that's really a testament to the program's success. We talked about workforce shortages here, but we know, as well as I think you all as a commission know, that there is a lack of qualified mental health and substance use professionals. It's one of the largest challenges that we see both in the field, but the MERS sites were also not immune to that. They talked quite a bit about the fact that as they need to refer to treatment, they need to refer to qualified clinicians and therapists. That was probably one of their biggest challenges, is being able to get to somebody who was qualified. So that is one of the things that we know is a key. I don't think it has anything to do with MERS so much as it is the state of the workforce, unfortunately, right now in the behavioral health field. But again, despite that, they were able to engage. The MERS teams, even with that challenge, were able to engage fully with places like hospitals, sheriff's departments. It is something that they continually said, in spite of that, they were still able to get help for the people that were in part of the program. I did hear quite a few comments about certification, that they were experiencing some difficulties in obtaining their certification. So trying to get more certified individuals into the field, that was one of the consistent themes that we heard as well. And then that limited number of therapists, again, that we continue to talk about. So sustainability, Mark mentioned this earlier, it's one of the greatest concerns around the MERS sites. So this is funded through state opioid response funding that comes through SAMHSA from Congress. And one of the biggest questions, as always, is Congress going to reauthorize SOAR funding? And if they don't, what's going to happen? So we dug into this a couple ways. We asked every site, how are you planning for sustainability? What are you looking at? What are you considering? So each of the sites, and what you see up there and on your slides, is what different sites said. Some of them said, we wouldn't be able to maintain this. Bar none, this would be a problem if SOAR funding went away. We would not be able to do this, and the community would actually be plunged into a crisis. Some did say that they were trying to figure out what other funding they would utilize, how they would do that. Some talked about if they could figure out a way with their Medicaid funding. Each of them was trying to figure out what they would do, but all of them said they were not at a place today that if this money was not reauthorized, that they could continue the program. And I think that's a critical thing to note. And we talk about that some are looking at alternative funding streams like becoming a recovery community organization. Others were looking at how they could potentially do adjunct services within the jails that would help fund their continued work if this went away. And as I said to every site, and I'll say to you, I never said that it was going away or that we thought it was going away, but we did have to ask the question. And of course, we continue to see that Congress thus far has been very supportive of SOAR funding. The limitations I talked about earlier with the grant only being able to serve opioids and stimulants, this is something that we heard repeatedly, and it is one of the areas where it posed a barrier to delivering care. So it was very challenging to turn away individuals. It's very hard for the peers also to have to turn someone away when they know they're in need of services. That's something that's a big challenge for them as well. The other thing we just wanted to note that, and we heard this from the teams themselves, that there is a little bit of a mismatch between the federal data collection tool and the services that they deliver, because that federal collection tool has a lot of different items in it versus what this program is specifically looking at. And so we'll talk about that in our recommendations, which are coming up. So a couple of things that we wanted to recommend. One is securing additional funding, given the fact that we never know if SOAR is going to be reauthorized, and we hope that it does. How can we identify and secure additional funding to continue to support this, to continue to expand this program and the good work that it does? We do recommend that every site has a minimum threshold for when they do submit that data, that critical GIPRA data, so that we can have a baseline of the same number of data that goes in. We do recommend that the state look at that. But at the same time, as I said, there's a mismatch between that tool and the data that we're collecting. So what we do recommend is that there's some consistent key performance indicators that every site look at, so that maybe, when we come back in a few years, we're going to be able to show you some of those KPIs that every site is collecting instead of just utilizing the tool from SAMHSA. The other thing I wanted to point out In 2 of the sites, they worked with IRACs, the IRACs program. Those sites said that they had really great interaction with IRACs, that they found both, they told us that, and in some cases, we were able to talk with the people that worked on the IRAC side, that this was invaluable to them. So much so that we felt it was a strategic recommendation that we needed to recommend that you continue to work with that program, potentially expand the connection to them. And then implementing some support networks for the MERS site. One of the things I haven't mentioned, but I think we all know, is that this crisis can often sometimes lead to grief and loss, and the peer recovery coaches see that as well. So this is a chronic relapsing illness, and we know that sometimes we aren't able to catch everyone, and we did hear from the peers that they would really appreciate support. Let me also say every site did say they did their best to support the peers when that happened, but we would recommend even more of a statewide network to support that staff as well. And with that, I want to first thank you all for listening. Thank the division for their support. I have really enjoyed being around the state, having the opportunity to meet every site. They are fantastic. They're a really good group. You should be really proud of the work that they're doing. And then I'm going to turn it over to Lynette and Maddie from Integrative Wellness.
Hi, I'm Maddie Combs, as she mentioned.
Yeah, and I'm Lynette Clark.
So I am the peer recovery support team lead with InWell. I'm a person in long-term recovery from substance use disorder, and I started as a peer recovery specialist back in 2019. It's the bottom click, right? So we have MERS teams in 3 counties, Clinton, Montgomery, and Boone. And as you'll see, each of our teams works very differently depending on the county that we're in. Each county has unique needs and unique support systems in place, and each county has different attitudes towards substance use disorder treatment, which in turn kind of leads to things looking very different from county to county. And we have been able to adapt to what a county needs, what they don't need, and fill in gaps where they have gaps, whereas other counties may not have had gaps. So the first one that we'll discuss is the Montgomery County. Sorry, I am nervous. I'll just put it out there because I talk about this all the time. I love this grant, but this is a new group of people. So, so thank you for letting me share.
So you're saying we should smile back at you?
That'd be great. So our Montgomery County MERS team, we launched in 2019 with this funding, and to speak to what Sarah said about this being so crucial for peers, it was so crucial for our peers programs. Our peer recovery team has just blossomed and grown tremendously through having these programs and these funding, and it has been amazing to watch. So in Montgomery County, we teamed up with the fire department, Mobile Integrated Health Systems. They were already creating a quick response team around the same time, so we just jumped in and said, hey, we want to do this too. How can we work together to make this happen? So we launched that in the summer of 2019, which was a 24-hour hotline that included access to peer recovery support at any time, anywhere, crisis response at any time, anywhere. We completely removed the gap of you have to wait 6 weeks till your intake, and then we can help you. So if they were in the ER and they called the hotline, we responded to the ER. If they were at a home with a medic and the medic called the hotline, we responded to the home. And this was such a wonderful, just smooth program to begin. So we also receive referrals through the criminal justice providers, probation, community corrections, the ER, medics, fire, and all community agencies. So then COVID happened, a little bit of a barrier, right? We weren't really being called to the ER and into people's homes. So we launched our weekly follow-up runs in 2022. We get information from the ER and from EMS, so we know where people have overdosed or had substance use or mental health related crises, and we're able to put them on a list. We go out with a licensed social worker and peer recovery and sometimes a chaplain, and we go out on Tuesdays and we follow up at their homes and check on them, see if they have the resources they need, see if they have appointments set up, if a discharge plan from the hospital, and we just try to work with them and find out what their needs are and how we can meet it. And we had 108 MERS encounters during the last grant cycle in Montgomery County. And a big piece of that was definitely implementing the follow-ups because as numbers dropped, it was harder to find people. So we've seen a lot of success with implementing the follow-ups, and we just continue to grow there. Oh, and I'm sorry, the jail, the Montgomery County Jail. So we do have a peer recovery coach embedded in the Montgomery County Jail. We started that in 2019. It got put on hold during COVID, and then we implemented it back in. And so we serve a tremendous amount of people from the jail. She has discharge plans set up for them before they leave. They have appointments for MOUD before they leave, if that's what they want. They have intake assessments. Housing. She does everything in the jail that a person seeking recovery would need leaving the jail. She's really great at making sure they have all of those set up before they walk out those doors. So I think that's it about Montgomery County. Oh, and there's the one for that. So she averages about 27 clients per month.
All right, so I am the managing member for Integrative Wellness, and I will echo that the peer recovery specialists have been one of the best additions to our practice, and just seeing the engagement that it allows and the pathways for recovery that we've seen individuals be able to choose and take has just tremendously helped our communities. As Maddie noted, each of our communities does look differently in how the MERS is able to fill some of these gaps that we're seeing, but I will say that it is so nice to know that for us as providers, let alone I can't imagine how it's feeling for our clients, just that the barriers that it does take away for our individuals we're serving. So Maddie mentioned the MOUD, and we have, through the MERS program, been able to partner with, help train and develop, but also hire our own prescribers. And so I'm so thrilled that for at least the communities we're serving, that is not a barrier today for us. We have access to that very critical care. Boone County, as far as our work within the Sheriff's Department, we have a really great relationship there. We have a lot of robust programming, I feel like, for a county jail, and we have just been so privileged to be a part of that in a variety of ways. MERS has really helped, again, plug a lot of gaps there, and similar to Maddie mentioning in the Montgomery County Jail, we are actually in the Boone County Jail every single day. We are able to, with our peers, begin immediately at bookend with individuals who want to engage with a peer to begin that recovery action plan, so that we do have a plan when they are released from jail. And we have such a great relationship that we're able to do a variety of things to just help people get from one aspect of care to the next. We do have the Peers in the ED program, which did start out under MERS. That is a program that our emergency department in Boone County, there's 2 EDs actually in the county, and we respond 24/7 to any substance use disorder, actually, that the individual wants connections with. And so we help facilitate higher levels of care in instances that that's appropriate, but we also are able to connect individuals with outpatient services in that ongoing follow-up. So that's been wonderful, and it did get its start through the MERS program, but our county hospital has appreciated this service, that they actually have sustained that piece of it. So that's been really wonderful, and we are happy to be able to continue that. And actually, the hospital chose to add mental health. So we are now on call 24/7 for any age of individual that's experiencing any kind of mental health or substance use crisis. So again, a big, huge lift from the MERS to get that started. I already mentioned some of the jail treatment. We do have quite a bit of programming within the facility, so happy to have that. And then we also are in Clinton County, which is again a unique space. So I feel like we have a lot of more access, I shouldn't say enough, but more access to resources in Boone County. And then once we get into like Clinton and even Montgomery County, it becomes more challenging. But what I will say is that the communities are really focused to find solutions and to provide by just, kind of wrapping around and finding the resources possible. So our provider does go out to Clinton County. So again, access to that medication-assisted treatment when appropriate. They have now access to our psychiatry services and therapy services. But there actually is through Healthy Communities, I wanted to mention, because they have their own peer program. So we had kind of helped them get that going and started and provided that support and oversight initially. And then they have just grown that. And so we just come alongside through the quick response team there, and also are doing similar follow-up calls to homes on a weekly basis or more frequently if needed to the community. I did also want to mention, because I know TI ROSC is a huge part of this, and I think that we have seen a lot of benefit from engaging stakeholders in our trauma-informed recovery-oriented systems of care. So we've been able to do things through the planning process that the group works on, from anywhere from prevention work to treatment. So some of the things I'm excited about is partnering with our local schools where we're able to get in, and our peers have been able to go in and actually teach a program. We have chosen This Is Not About Drugs in the communities we're working in, but has been well received, and I think very important piece, and that has all developed just as a part, again, of being able to work with the MERS. So can't say enough about it. Again, the taking away someone's barrier to not be able to pay for their medication is just such a huge thing. So Maddie had some closing words here.
I just wanted to say that MERS is so valuable to the continuum of care because it allows us to stay connected to a client from the very beginning, all throughout their treatment and recovery journey. And that is my favorite piece of it, because without it, I just don't know if that would be possible. And the evaluation really highlighted to us that the work we're doing is making a difference, and we plan to take that feedback and continue to grow and reach more people.
I'm just going to quickly wrap it all up here and put a bow on this. So the evaluation that was completed in phase one of our planned work with Third Horizon Strategies. This evaluation report has already been shared with all of the MERS providers and will soon be available to the public. In fact, I think a couple days ago, Third Horizon published it onto their website. The work with Third Horizon Strategies is currently in phase two. Third Horizon Strategies will be working to gather information from MERS providers and other stakeholders to help DMHA devise a more sustainable model for future grant years and beyond. Some questions yet to be answered in phase two include: 1, how do we implement Third Horizon's recommendations? 2, what can be improved about this model? 3, how do we sustain MERS without federal discretionary funding? And finally, how can this be replicated in other Indiana communities in a sustainable way? Here is my contact information. Please feel free to reach out with any questions. Thank you for the opportunity to present today.
Well, thank you, Mark. Are there any questions for any of the presenters?
I've got one quick one. Ladies, you made reference to Clinton, Montgomery, and Boone being at different levels of collaboration with you. You said Boone was better than Clinton and Montgomery. Can you give us an example of a thing that a county has to do or should do to be successful? The reason I ask is the leadership in two of those counties overlaps. I'm just curious.
Gotcha. I think
Just curious what they're doing in one that they're not doing in another.
Well, from my perspective, I think it's more about resource, honestly, unfortunately. So that's a harder thing to really, I think, resolve. When we're getting more rural, we have less resource. I think that the counties all, and honestly, sometimes in our smaller counties, may actually be partnering and working even closer together, honestly, with those leaders. So I do believe that that's happening. And I think they're doing, I guess, the best with what they have, right? Whereas in Boone, luckily, and we still have resource issues, so I don't want to make it sound like we don't. So But we are able to, we have closer proximity to the Indianapolis area, to other, so people that may be social workers, for example, that will travel to Boone County to work, but they're not so much ready to travel to Montgomery and Clinton County to work, if that makes sense. So that's my perspective on that, but, yeah, you're welcome.
Dr. Fleming.
Thank you. Hopefully, the federal funding will continue, perhaps be expanded to include other substances. But if not, and we're looking at more state funding, legislators don't want to see an unending ask. And we know Senate Bill 1, came up with a decent amount of money, but not nearly enough. You mentioned preventative efforts by going to schools. Didn't someone say that you are reaching out to schools? So what are you doing in terms of prevention so that the next generation is not so involved with substance abuse disorders?
I can say just a little bit that our prevention teams are very much at work in our communities, and we have made great attempts to connect our regional prevention coordinators that are funded by DMHA, who help serve as liaisons in the community, to help connect them with the MERS teams, to help make sure that we're all talking to each other and we're all planning together. I think prevention definitely has a serious element, a serious role to play, for sure, to make sure that we are stemming the tide of this opioid epidemic. But I think that is further to be seen, that yet to be seen, and we'll see how DMHA progresses with its prevention strategies.
Okay, one other question. For those on medication-assisted treatment, is there an effort, or is it seem possible that a weaning process is expected, or I guess every person is an individual in how they're treated, but again, is this going to be something that is generally lifelong, or is it a withdrawal, weaning sort of thing?
Yeah, well, I'm personally not a physician, but I can say that I think every doctor or physician, prescriber of medications for opioid use disorder would look at it as a person-by-person basis. Everybody's needs are different. In some instances, I do know that it is necessary for somebody to be on these medications for a long time. And this is all about, improving quality of life. And whereas somebody might be on insulin medication for diabetes for the rest of their lives, they also may need to be on some kind of medication. So we don't prescribe that, somebody has to be off their medications, not from a MERS perspective or anything like that. But we do rely on our medical professionals in the field to make those determinations. And it's all about saving lives and keeping that person alive and keeping that person on the road to recovery.
Okay, thank you.
Bernice.
Thank you. My question is around the quick mobile response teams. And I've been sitting here trying to get my Indiana drug overdose dashboard to open, but T-Mobile is not cooperating right now. So the point I'll make is based on seeing the heat map a couple of years ago. So I'm curious to know, if I heard correctly, it seems like Clinton, Montgomery, and Boone have the quick mobile response team. And I'm curious to know, if that is correct, how were those counties chosen? And is there a plan on expanding the quick mobile response teams? And, what about urban areas? Because as I recall the heat map, there were a lot of overdoses in a lot of urban areas around the state. So I'd love to hear your thoughts.
Yeah, so the quick response teams, many of them were selected in previous funding. Some of them were started under previous funding of the 21st Century Cures grant that preceded the SOAR funding. This was all done through a competitive RFF, or request for funding. So the counties that applied were the ones that were interested in implementing the model. Boone, Montgomery, and Clinton are not the only ones that utilize the quick response model. Some have modified it into something a little bit different. I think the quick response team model that is developed out of Coleraine County, Ohio, is really the model, but we've allowed people to adapt it as they need it. Trying to remember what your other question was.
If there were plans to expand, if there were plans to expand it. But now that I'm hearing your answer that these sites were chosen through a competitive grant, it sort of relies on communities seeking it and being selected.
Absolutely, and we'd love to expand this, but my philosophy is begin with the end in mind, and that we don't want to start a program that doesn't have a sustainable future. I would love to see all 92 counties have this service, but it's not free, and we need to make sure that we are sustaining it in a responsible way. Thank you.
Representative Ledbetter.
I wanted to ask, what is the hurdle with the certification with the social workers?
It's a good question. I think we'll have to do some investigating into that. I imagine it's some systemic issues with getting folks, their exams and requirements for their licensure, but I haven't too much into that.
And I just wanted to mention one other thing. I am a psychiatric nurse practitioner. I work in mental health. And I know some of my patients pay $100 a week to some of these medication assistant treatment programs. That's a little bothersome because I feel like there is a potential for them to continue to keep these people on these medications because they make a lot of money off of that. Do these MERS programs, do they provide the financial cost for the people that are involved in this?
In some instances, if somebody does not have a third-party payer, as Indiana Medicaid pays for medications for opioid use disorder, private payers, commercial payers are supposed to be paying for that. Some people do fall through the cracks, though. Actually, way too many people probably fall through the cracks. So MERS teams are able to help with that funding. Nobody in MERS pays a dime for the services. So anything that would come, but we always want to try to make sure we're exhausting those existing funding resources first. So I do understand your concern there. We just want to make sure that we are handing the payment of these services to payers who have that in mind, that they don't want to be taken advantage of.
Any other questions? Chris?
I had a question on some of the data on the jail programs. So when you provide the referral services and treatment services, you noted in Montgomery County that 27 clients per month. Could you give a ballpark as to what is the percentage of incarcerated individuals that you think could benefit from your services that actually take you up on receiving those services?
I have a better indication of that, I think, through Boone County, but we really do get a lot of individuals. So I'm trying to think in terms of percentage what that might look like, but we get a lot that reach out they can communicate with us on the kiosk, right? And so they're requesting those services. And we are fortunate that MERS isn't our only program, so we have a variety. So, we're serving, I would say, probably, around 20% maybe. And it may be a little higher because it is hard to kind of quantify all that with the in and out that is happening within a county jail. But I think we've done a fabulous job with our peers in kind of making that initial contact. The jail has a way to let us know that someone has left. So we are capturing the individual, but to have that actual data, I would say now that's probably what I would ballpark as far as a percentage. Yeah. Thank you.
Just to follow up, for those incarcerated individuals who are involved in the program and maybe start medication, what are the barriers when they get out to continuing that medication? Because we know that leads to recidivism. If they can't continue their medications, go back into the drug world, and then they're back in jail.
What I'm excited to say is because of this program, there's not a ton of barriers. We have prescribers available. Our peers are making appointments before. Now, there is that potential that the individual doesn't stay engaged for some reason or another. The other wonderful thing, our medical director in our Boone County program is she's actually an infectious disease doctor as well as treats with MOUD, and she contracts with our practice and is herself in that Boone County jail, and so these same patients can stay with her for continuity of care on the outside, as well as one of our psychiatric mental health nurse practitioners. So it's really exciting, and I was just talking with the jail commander the other day, and it really still remains, our jail program remains one of the favorite things that I've been a part of in my career, so.
All right, thank you.
Yeah, thank you for the question.
Mine is more, I think, of a statement than a question, and I found it really interesting. I'm a data nerd, so I like to dig into that. The social connectedness, where there was some maybe concern of a drop in social connectedness, I almost wonder if that's actually a positive thing, because they're not going back to the same community that led them down that way, so that might be something to dig into.
I thought about that as well as a possible positive. Any other questions? I do want to ask, so the GIPRA used to be a top 3 complaint. And I have not heard anybody complain to me about the GIPRA in quite a while. And this is a question for anybody. I mean, is it still problematic? I mean, why is nobody complaining? Is it because we haven't done anything?
We resigned
I can,
ourselves to it.
I can speak from the state side. There might be a couple answers to that question. I think more and more providers are utilizing the GIPRA, and we have the ability at our team to share GIPRA data back. So the GIPRA is, if you guys have not heard, it is a 30-page assessment that the federal government has us collect. Not everybody who receives a service through MERS gets a GIPRA. But for those that do, it is a task to complete. The GIPRA form was changed in January of 2023, and we had some downtime during this year in which we weren't able to enter and submit GIPRAs to the federal government. So there could be a lapse where people weren't as plugged in with GIPRA for this downtime we had. Now, I will say that in the last, we've reinstituted this program for this uploading and submission of GIPRA data to the feds as of September 25th, and we've had over 1,100 GIPRA forms submitted as of today. So I do think that the change in the form that was done in January has also helped. The questions are different. They're a little less invasive, a little less intrusive, but it is still a hefty assessment that folks have to do. But we want to make sure that the data is not just a one-way street, that it's not going into a place and then going anywhere. We have quarterly meetings with each MERS team to share back the data with them. So it's not going into a black hole. They're actually able to use it to better inform their practices and better inform their communities. It's also a measure of sustainability too, if you're going to apply for a grant to have data to support your work.
Any other questions? Well, thank you, Mark, Sarah, Maddie, and Lynette. We really appreciate the work that you are doing. I do just want to comment Representative Fleming's question about prevention. We just had a meeting this week looking at how can we, when we have these MERS teams who are interacting with individuals, and oftentimes there are children who are present throughout a lot of this. And so how do we, knowing that they have risk factors, that there's a lot of other stuff going on, how do we use our prevention team at DMHA to begin to deliver some additional services through prevention programming and connecting them to other services in the community as we engage with individuals, also not just looking at the children, but also their families as well. So,
Can I comment on that? I've been meeting with a group called ROCK, Raising Our Children's Kids. And it's a group of anywhere from 8 to 10 grandmothers who, through various circumstances, now have some sort of guardianship, foster, adoption relationship now with these children who are in their homes. Some choose to, or some are involved with the DCS, some are not. It's estimated that there's about 59,000 relatives, mostly grandparents raising grandchildren. I think that's a gross underestimate because those who are not involved with DCS, we don't always know about them. and these people get nothing. Maybe a medical card, and many of them are on pensions. I could tell you stories about people who literally had a baby dumped in their lap that they didn't even know was expected, and now have to buy cribs and diapers and raise this child. And maybe in the next topic, the opioid settlement, maybe we can find some way to help these folks. They need help legally, they need help financially, they need help with their own mental health, because oftentimes they have lost their adult child or lost contact, and now they have this additional responsibility that's pretty overwhelming.
Yeah, absolutely. All right, well, thank you. At our August meeting, we shared an update on the status of our $52 million plan to utilize the 35% share of the state's half of the 2022, 2023, and 2024 payments from the National Opioid Settlement. I've asked Emily Truelove, who's been very busy, she is DMHA's Opioid Settlement Manager, to share more about those awards and our current opportunities that are out on the street. Emily?
Thank you, Chairman Hunsinger. Here we go. And thank you, Commission, for allowing me to come and present. My name is Emily Truelove. My pronouns are she, they, and I am the Opioid Settlement Manager for the Division of Mental Health and Addiction. And I plan on just, providing just a brief update of just what's been going on within DMHA and how we've been spending some of these opioid settlement funds. So the first one, the last commission, this is to serve as a reminder for you all. So for the first grant that we released was RFF 2023-007, which is known as the Opioid Settlement Match Grant. And so the goal of this one was to help communities and counties collaborate and build connections to infrastructure and implement evidence-based programming. And so as just a reminder, this is the one that we received 78 proposals that total to a $93 million request. And we were able to award 30 of those proposals that totaled around $19 million. The contract dates for this started in July of 2023 are going through June 30th of 2025. And currently there are 28 of those 30 contracts fully executed. We only have a couple left. I know in your printouts it might say 27. We just had one at the end of the day yesterday get executed. So that's that update. And then some of these projects that were funded included all of these various areas. So prevention, treatment, recovery, etc. So then the next RFF that we released was RFF 2023-012, and this was for capital expenses for recovery residences, and we received a total of 44 proposals that totaled about $25 million ask, and out of those we were able to award 8 that totaled a little over 4.7 million. And the contract dates for these awards started October 1st of 2023 and are going through September 30th of 2024. Currently, all 8 of these awards are being processed through our contracting system. And what was funding through this was that there was purchase of property in order to become a recovery residence, as well as construction of a recovery residence building, and also if someone owned already a building but needed to do some renovations, that also was able to be funded. So the goal of this was for us to add beds and access to recovery residences for individuals who are in recovery and who would like to have the extra support of living with other individuals in recovery. And exciting news is that we were able to have a total number of beds added was 206 beds. So with that being said, I'm happy to announce the 8 organizations that were awarded this funds. So the first one we have is Bridges of Hope, who is located in Madison County. We also have Dove House, who is in Marion County, Inspiration Ministries in DeKalb and Noble counties, as well as Lawrence County Recovery, who is in Lawrence County. And then we have Lifehouse Ministries, that's in Hamilton County, Next Step Foundation, Inc., which is located in Clay, Park, Putnam, Sullivan, Vermilion, and Vigo counties. And then Overdose Lifeline in Marion County, as well as Stability First in Morgan County. And again, through these 8 organizations, we were able to add 206 beds around the state for recovery residences. So the newest RFF we just actually put out is RFF 2023-0016, and this is for harm reduction street outreach teams. So the goal of this one is that these teams are to help meet individuals where they are in their recovery journey and help create positive behavior change no matter how big or small. And so in this, we released this funding opportunity on October 2nd of 2023. Proposals are due by November 20th of 2023, so this is active and open. Oral presentations are being conducted instead of written proposals. We're asking for oral proposals, and that's going to happen the week of December 11th through 14th. And then the applicants who applied would be notified of a decision by December 21st of 2023. And then the project timeline for our street outreach teams expansion is January 1st of 2024 through December 31st of 2024. And again, this is meant to be an expansion of the harm reduction street outreach teams that we funded back in 2001, or 2021, excuse me. And we started off with 10 teams then. So then the goal of these outreach workers, again, is to help meeting people where they are by distributing naloxone, referrals to treatment, housing, employment, peer support, and other community resources. And so with that being said, select organizations will form these harm reduction street outreach teams, and they will have 2 of these outreach workers as well as 1 supervisor. The harm reduction street outreach teams will also have knowledge of local community where illicit substance use occurs, and we will be able to award applicants up to $200,000 each. And then the priority we're giving for this request for funding is for those who are serving minority services as well as located in specific regions of Indiana. So specifically the southwestern, south central, central, and western regions of Indiana. And the reason for that is through our current harm reduction street outreach teams, we know is the gap in these areas. So we wanted to make sure when we expand, we try and service these areas. And then with that being said, speaking of our current outreach teams, I just want to provide a quick update. It's been a while since we updated this commission about how that's going. So we started with our current teams, street outreach in January of 2022. And this is preliminary data that I just received from our evaluation team. And so from January 2022 through August of 2023, we were able to distribute 41,973 harm reduction kits. And also our teams were able to serve 102 unique zip codes around the state. So that's just a quick update. We're hoping to have the final report by the end of the year.
Questions for Emily? All right, well, thank you. So this summer, I had the opportunity to meet with some of my counterparts from across the country. And Indiana is one of just a handful of states that is getting money out the door. So I want to thank not just DMHA, but many individuals from your agencies have been participating. We've taken a multidisciplinary, multi-agency approach to these proposals. And so we've had lots of different individuals who've been participating, helping us evaluate those. I think we showed the picture at the last meeting, but I mean, each one of these has been a significant lift, with just the volume of information that's submitted, that's reviewed. And so I want to thank all of the work across all the agencies that's happened. Also in August, the commission voted to approve the fields for reporting for use of settlement dollars as required by the legislature. And we received reports from 606 of the 648 local units of government that receive settlement funds. And so of the communities that reported the use of their funds, 81% had not taken any action with their abatement funds, and 87% had not acted with their unrestricted funds. The report that was submitted to the legislature on October 1st is available on our website at in.gov/recovery/settlement. And we're working on continuing to update the website to show, as we do this reporting continually, to show how money is being spent in alignment with Exhibit E, and also what percentage of total funds across the state have been spent, to give individuals a bit of a dashboard on where this money's going and how it's being utilized. So now I'll toss it over to Devin McDonald, Director of the Indiana Criminal Justice Institute.
Thank you, Chairman. I'm just going to be real brief. Couple updates. So our LCC year-end report is finally kind of being wrapped up. I will apologize. I will not be providing printouts because it's over 200 pages. However, once we're able to get that on the website, I'll be sending a link to that along with our LCC dashboard, which is on our website. That gives a good breakdown of the LCCs around the state, kind of their liquidity and the kind of funds that they have, as well as what they're spending their funding on. So I'll be sending that out, hopefully here in the near future, so we can send that out to the commission for your viewing pleasure. Michael Ross, our Division Director, Behavioral Health Division Director, has been pretty active reaching out to the LCCs, doing a lot of collaborative work across the state to try to partner with folks, put in some new frameworks on expansion of how they can grow themselves, as well as increase their health and wellness as organizations at the local level. Did a presentation a couple weeks ago. It was very well received, so doing a lot of great work there. And continuing to put on a few new presentations on some frameworks and development again for LCCs to be a little bit more helpful to themselves and kind of coalition development, which has been an ongoing issue over the last several years with those. So that's about it.
All right, thank you. Any questions? Dr. Fleming?
Thank you. Referencing what I was talking about earlier, is there some way that some of these settlement funds can be used perhaps to assist with the legal aspects of relatives raising grandkids because of the drug crisis?
I don't know the exact answer to that. I'd have to look at Exhibit E, but I'm happy to dig into that and get back with you. There are a number of guardrails around how this money is spent. They range from very specific to overly broad. So I'll take a look and get back with you on that.
Thank you.
Yeah, thank you. I'll just report that the 2023 Next Level Recovery Progress Report, reporting on all of the work across the state that's taking place, will be distributed in December, and we'll make sure that this commission gets a copy of that report. I want to thank all of our presenters this morning. I appreciate everyone's time and attention and your flexibility with our scheduling of our quarterly meeting. Our next meeting is February 2nd at 10 a.m. in the Indiana State Library History Reference Room, and we will be sure to send calendar invites for all of the 2024 meetings for next year. So thank you. We stand adjourned.